And usually you will have some simple language tasks on the cognitive screen that you're giving, like the Mocha or the Slums. But if you don't, you can just give them simple yes no questions to see if they can follow what you're saying on a very simple level. You can give them single step commands to see if they can understand what you're talking about. And it is easy to increase the difficulty of the task that you're asking them to respond to as you test receptive language. One of the things that I often do is I'll go in and I'll just introduce myself and I'll give a short biography. Like, I grew up Haleyville, Alabama. These are the things that I enjoy doing in my life. This is my job. And then I'll just ask them questions about what I just said. And that is sort of my quick, down and dirty way of testing for receptive language. But also, you're roping in short-term memory when you give them information and then ask them to recall it. So the longer your explanation, the more it's going to pull on their short-term memory abilities. The shorter your explanation, your story about yourself, the less it will. I've got a story where I got lost in the woods because of my dogs, chasing my dogs, and it created a situation where I basically almost died. And I used that story in the nursing home for like 2 months to test people's receptive language and their short-term memory. And they loved it because it was entertaining, and they liked to hear that I screwed up in this way. And of course, how they respond to your questions is going to give you an idea of their verbal expression capability. If I didn't want to give them a short narrative about myself and then elicit language from them about that, I could simply start at a much lower level with confrontational naming. What's this? It's a spoon. What's this? It's a cup. And then go into more higher level things, like giving them a narrative, like engaging them in simple conversation. But you always want to have a good understanding of what their language abilities are before you go into the swallow evaluation, because you're going to be asking them questions. Does this hurt? Right? Did you swallow that? That they need to be able to answer, and you need to be able to understand if they can't respond correctly to those simple inquiries about the swallowing evaluation. As a part of your oral motor evaluation, you should be listening to their voice, the quality of their voice. You want to be thinking about, do they have too little adduction? In which case maybe they can't, maybe not only can they not adduct the vocal folds for speech, but maybe they cannot adduct the vocal folds for swallowing. So asking them to produce a vowel as long as they can, and this is your sort of quick measure of maximal phonation time, and that's going to give you a good idea of vocal quality, but it also should give you a pretty good idea of respiratory support as well. When you ask them to take a deep breath and produce a vowel, you want to see their chest lift as they take a deep inspiration. If you ask them to produce as long a vowel as they can, and what you hear is more adduction, more strain, and less airflow, like this, that one thing that might be telling you is that patient doesn't have appropriate respiratory support, and to compensate for that, they are using a greater than normal level of medial compression of the vocal folds to really drag out what respiratory support they have for phonation. You always want to try to elicit a cough, and it's going to be like, all right, let me hear you cough. And you're going to need to model for it. You're going to need to model a strong cough to them, because it's almost universal. You ask them, all right, let me as strong a cough as you can produce. Unless you model it, they're going to go like that. So you have to say, no, deep breath, and you really give them this visual image of strength. You want to really take a deep breath and put in as much effort into it as you can. And you want to try to do that so that you can hear what their best case scenario for their cough might look like. Because if they can't produce a cough at all, if they're doing that, then there's not enough adduction for a cough to happen, then they're not going to be able to expel anything out of their airway. You also generally want to test for the presence of oral apraxia. So when we say apraxia of speech, this is your inability to program your articulators for the appropriate production of speech. Nonverbal apraxia or oral apraxia, there's a few different phrases that we use to refer to this disorder, is an inability to move your mouth for really any volitional purpose. Sometimes they can get automatic movements in there, but for instance, asking them to lick their lips, if they have oral apraxia, they're going to struggle with that. They're going to have lots of groping with their tongue. Another common command we use is like pucker your lips, like you're going to blow me a kiss. Show me how you blow out a candle. So the presence of oral apraxia can complicate mastication and bolus manipulation if it negatively affects those things. But there's usually some degree of preserved automatic movement in oral apraxia. It tends to more negatively affect like more volitional movement, where you're more trying to think about how you're moving your mouth. The good news is for those patients that have very serious receptive language deficits and they can't understand your spoken language cues about eating or going through the swallowing evaluation, is that you can usually communicate these things very well with visual cues or gesture. And this is just because the process of eating and drinking is so deeply ingrained in us as individuals. We all know the process so well that when someone says, I want you to eat this here, and you're using facial expression, eat this, right? Or if someone is reaching a spoon out to you, or you are reaching a spoon out to someone else. This is gestural functional communication, so you usually don't need a great deal of language ability or even cognition to pull this off. And this is why you see when we work with people with dementia, you can have people that have pretty severe dementia that still understand the process of feeding, that still understand the process of eating and drinking. So the oral motor evaluation is very important, super important for your swallowing evaluation, because all these structures that you use for speech that you thought about and you studied in your motor speech course, all those cranial nerves and the muscles and the structures they innervate, this is the same anatomy and some of the same functions even that you use for mastication and deglutition. So if I can't move my tongue for the production of speech for articulation, there's a pretty good chance I'm not going to be able to move my tongue for the purposes of bolus manipulation or AP transit or lingual retraction. All right, so let's talk a little bit about this conversation you're going to have with the client where you're asking them about their swallowing, you're asking them about their symptoms. First of all, it's common that you get referrals that are not necessarily based on a patient showing swallowing disorder symptoms, but just their primary medical diagnosis. In some facilities, every stroke patient, if a patient comes in with a stroke, that automatically generates a speech referral in which you will check their swallowing. Not always, that would be a best case scenario, but sometimes. So you have to consider that in an acute care setting, these are the clients that just came into the hospital a couple of days ago or today, and they are medically compromised. They have lots of stuff going on. If they have a swallowing problem, they probably just got it, and they might not know about it. They may not understand it. So when you're asking them questions about it, they might be answering incorrectly simply because they're unaware of the situation or they don't understand it yet. Or maybe they're just in extreme pain and they've got so much going on that it's not even on their radar. So sort of the standard questions that you start with is, are you having trouble with your swallowing? And like 8 times out of 10, the patient's going to say no, even though most of them probably are. So they'll say no, and you'll say, all right, but you're thinking, that doesn't really help me too much. And so then you'll ask, do you choke a lot, or do you cough after you swallow, or you do any throat clearing? And they may answer yes if that happens to them. They may answer no because they're unaware of it, or maybe they just don't want to admit to it for some reason. And usually the best thing to do is you just put a cup of water out front and say, yeah, here's some water. And if you're not doing an evaluation of the swallowing, you can't force them, you can't ask them probably even to take any liquids, but you could say, oh, here's the coffee that you wanted, or here's some water. And when the patient takes that drink, you wait, and usually it looks like this. They take a drink, and you say, you have any trouble swallowing that? And they're like, no. And they'll start doing that. And you'll be like, well, I notice you're clearing your throat a little bit. And they're like, yeah, it doesn't have anything to do with my swallowing, though. That's just something I do after I drink coffee, or something I do after I drink water. And you'll hear that a lot. They don't connect the two. Another question you want to ask is, do you get food stuck in your throat, or do you have to swallow like more than once to really push the food down? And keep in mind that if you're in the acute care setting, there's a good chance these guys are going to have some language impairments. So yes, no questions might be difficult for them. So you having maybe some yes, no cards or a communication board would help facilitate that communication between you and the patient, because your aphasic guys, even if they can say yes and no, they famously get them reversed. So you sort of have to double check the person with aphasia on their yes and no questions if it's like really important that you actually know the correct answer. For your rehab patients, for your outpatients, these are your guys that are probably medically through the woods. So they are more with it. They're more aroused. They're more functional. They have been living with this condition for probably some time. So they're probably able to answer more pointed questions about it, as are the caregivers. So this is where sort of like you ask questions such as, when did this all begin? Did it begin abruptly, or was it gradual? Now, if you ask these questions to someone in the acute care, like, when did this begin? And they're like, yesterday when I got hit by that car. Did it begin abruptly? Yeah, when I got hit by that car, right? So these are questions that in a lot of ways would be inappropriate in the acute care setting. But for someone that has just been referred to you as an outpatient, or maybe they have come from the acute care hospital into your rehab hospital or your rehab clinic, these questions are more appropriate. So, has your swallowing gotten better over time? Has it gotten worse? Does it get worse throughout the course of the day? Because oftentimes, if like fatigue is a factor, muscle fatigue, which is with some conditions, then they'll say, well, I'll wake up in the morning and I'm able to swallow fine, but by the end of the day, swallowing has become more of an issue. You hear this a lot in myasthenia gravis and in post-polio syndrome. You always want to ask the client, does it hurt when you swallow? Or where does the food get stuck? And if so, where? But understand that when they point to where the food gets stuck or where it hurts, that's not always that's where they're feeling that sensation. But it does not necessarily correlate with where the problem actually is. So oftentimes, patients with the food that is not passing through the esophagus appropriately will still point to their neck, sort of behind the larynx. That's where it's getting stuck. And that's where the UES is. And it is common for patients for the UES not to be open appropriately. That's even like something that happens with normal aging. They have to go in and dilate the UES, and a lot of just otherwise normal individuals, because their UES is getting tight and they're having trouble getting solid boluses into it. But just to put it on your radar, when the patient says food is getting stuck here, maybe they're correct, but the patients with the esophageal problems tend to point there as well. Oftentimes, you can ask the patient, what consistencies, what types of food do you struggle with? And if they've been dealing with this for a while, they'll already know, and they could give you a pretty good layout of the things that they struggle with. And a similar question is, do you avoid certain foods or liquids? And that will also tell you the consistencies that they're trying to avoid. And down south, it's cornbread is sort of the number one culprit for if a patient is having difficulty swallowing, more often than not, they're going to struggle with the cornbread because it's so crumbly and it's so dry, it's difficult to keep that bolus together. So unless you have really good pharyngeal squeeze and really good mastication and bolus forming abilities, you're going to struggle with cornbread. Steak is another food down here that people struggle with, usually, not always. And like as I said, oftentimes they will have identified the foods that they struggle with, and they will have already figured out how to manage it. So it may be just not eating those foods entirely. It may be doing something to the food. Maybe the wife cooks it and makes the cornbread more wet, which makes it go down much easier, for instance. And also, if you have a patient that has like trouble with a specific food, and it's like they really want to be able to eat that food, then have them bring some of that to the swallow evaluation. Popcorn is something that I've had 2 or 3 end-of-life patients really want to be able to eat. And they came in for the modified barium swallow, and I said, you struggle with popcorn, but that's the main thing you want to eat. And it's like they have a feeding tube, but they just want to be able to eat popcorn. I'm like, bring the popcorn. We will try all these different things to try to get that popcorn safely down your throat. And if you ask, have you lost a lot of weight since your swallowing problem began? If they have, then that tells you that it is a serious swallowing problem. If they are avoiding eating, or oftentimes it will be with the odonophagia, it'll be the pain with the swallow. They just won't eat. Those patients will usually lose a lot of weight. And as SLPs, we need to be very focused on quality of life, because whatever we do should be working towards a higher level of quality of life for the patient. If you're going to do something, if you're going to work on their swallowing, that needs to translate somehow into better quality of life. There are different ways that we assess it, but there is a survey called the SwalQual that we often use, and it documents these aspects here of the patient taking food. And this is good to give as a baseline measure before therapy, and it's good to give at the end of therapy, so that you can show an improvement in the patient's quality of life. So you always want to do an oral motor evaluation. Some people use the term cranial nerve evaluation or cranial nerve exam. It's basically the same thing, because when you're evaluating all the structures of speech and swallowing, you're essentially seeing if those nerves are working. So you're going to want to look at the structures in their mouth. You're going to want to see how their structures move, range of motion, and strength. So you'll look at the lips, the symmetry of the lips. Can they retract it this way? Can they retract it this way? Both ways. Can they pucker and smile? So range of motion. And then you want to take a tongue depressor and hold their forehead and have them push against the tongue depressor, pucker against the tongue depressor, which tests strength. Also, have them blow their cheeks up, and then you want to squeeze their cheeks. And they should be able to hold a certain degree of pressure in their oral cavity. And if not, then that shows you a weak labial seal. So if you're able just to squeeze the air right out of their cheeks with no resistance, weak labial seal. And a weak labial seal is going to translate into perhaps facial nerve issues. So you want to look in their mouth. You want to note, is the oral mucosa, does it look healthy and wet and pink? Is there like excess saliva pouring out of their mouth, or saliva pouring out of their mouth at all? If there is a lot of drooling going on, that probably indicates to you that they're having trouble dealing with it posteriorly through the pharynx and esophagus, like everyone else normally does. You want to look for any lesions in the mouth. Is there any pocketing in the buccal cavities? Which means, is there food left over in the buccal cavities? Do they have teeth? What do the teeth look like? How many teeth do they have? Are their teeth functional for mastication? If they don't have any teeth, do they have dentures? If they have dentures, where are they? They're usually not there. Usually you have to tell the nursing or family or somebody, he doesn't have any teeth. He needs his dentures, so someone find them and bring them here so that he can eat. Oftentimes, they just won't have their dentures. They won't have their glasses. They won't have their dentures. They won't have their hearing aids. They're afraid someone's going to steal them. I'm like, well, and yeah, on some level, I don't know what to say. But oftentimes, I'll be like, look, if someone steals them, I'll buy you some new ones, right? But in the meantime, you need to be able to hear, eat, and see, right? And no one's taken me up on that yet as far as paying for lost glasses. So to test for the trigeminal, you guys know this. This is the nerve that innervates mastication, the muscles of mastication. So you put your hand under their chin and have them lower their mandible against the resistance of your hand. And then turn your hand over, put it here, have them try to close their mandible against that resistance. You can have them close their teeth and bite, and you feel the masseter pop out here. The masseters should be basically symmetrical. They should be the same. If one side is atrophied and one side has this big masseter over here, then that tells you that they're masticating on that one side where the masseter is overdeveloped. Testing the facial nerve, you want to look at the symmetry of the face. Like I said, have them lateralize their lips one way or the other, pucker and smile. If it is a unilateral facial nerve issue, then the forehead and the eye and that side of the mouth will be affected. So facial nerve, it's going to affect the entire unilateral, ipsilateral side of the face. So if there is no wrinkle on this side of my forehead and there is wrinkles on this side of my forehead, then that tells you that this side of my forehead, the muscles aren't moving. They're not contracting because there's no wrinkles. And there's probably, take that together with the ptosis of my eye and a weakness of this side of my mouth, that's going to tell you you have a unilateral facial nerve issue. And also, as I mentioned a second ago, when they puff up their cheeks, that shows you how good their labial seal is. And that gives you an idea of a cranial nerve, of the face function, of the integrity of the facial nerve. So testing the glossopharyngeal at the soft palate, and the vagus does some of the soft palate as well. Basically seeing during speech, are they able to produce nasal versus non-nasal phonemes? During your oral motor eval, probably asking them to imitate you like this, nga, 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 nga. And that is me phonating and opening and closing my velopharyngeal port with the soft palate. And of course, your vocal quality gives you an idea of the function of the vagus, as it is responsible for the muscles of add and abduction. How well they're able to cough also gives you an idea of that add and abduction, and that can give you an idea of how well the vagus is doing. Testing of the hypoglossal is testing of the motor movement of the tongue. So protrusion, retraction. Protrusion and lateralizing that tongue one way and the other. Lateralizing the tongue one way, and the other pushing against a tongue depressor to test for strength. Having them put their tongue in their cheeks and then pushing on it. So it would be like, all right, I want you to do this, put your tongue in your cheek. I'm going to take my hand and I'm just going to push on it. All right, resist my hand. Having them protrude their tongue, try to touch their nose, point it down. You want to observe the tongue at rest. So you want to look in there. The tongue should be nice, pink, symmetrical. There shouldn't be any hyperkinesias or fasciculations. Fasciculations are motor fiber level contractions. So the tongue basically looks like it's overall it's sitting there still, but the surface of it looks like it's doing this. That is indicative of lower motor neuron damage, which, if you're talking about the tongue, is indicative of the hypoglossal. Now, I don't do a lot of sensory testing. Unless I'm really digging in to try to tease apart some threads with what's going on with the patient, because it just adds that much more time, and more often than not, it's not a huge payoff. And one of the reasons for that is, you don't need to be able to taste to really be able to take food appropriately. And also keep in mind that when you're asking them to participate in this oral motor evaluation, this is not a natural kind of thing. This is not the natural way in which you move those structures. So when I was talking about oral apraxia, patients may be unable to do these movements of their mouth in the context of you modeling it and trying to elicit it. But in a functional scenario, they may do those movements automatically without thinking about it.